Ben Gerhardy. I'm a respiratory physician here at Nepean. I'm doing my critical care DDU, and I know a little bit about thoracic ultrasound because I'm a big believer in it and don't do it near as much as I'd like. So I guess the overall question is why look at the lungs? And I think whenever we go into a scan, just like we do with echocardiography, you have to work out whether you're doing a proper thoracic ultrasound or whether you're doing a focused thoracic ultrasound. Because if you have a specific question to answer, then that's what you go and look for. And I think, well, I suspect that's what most of us do on a day-to-day basis. If we're scanning a pneumothorax and effusion, we're scanning an area that we're suspicious is consolidated. But I want to make it clear to everyone, because I suspect there are some people that don't realize that a proper formal multi-region thoracic ultrasound is a very useful tool. It's a very useful diagnostic tool. It can be useful for monitoring progression and change. And you know, historically, the idea of ultrasounding the chest was never been accepted until the last 20 odd years from people like Liechtenstein. And slowly but surely, I'd like to think that thoracic ultrasound is getting more of a, it's getting more prominence within the newer generation of trainees and consultants. Given that I suspect I'm speaking to a virtual room full of predominantly intensivists and intensive care trainees, I'll try to not hang too much on my own specialty, but I will say that there are some of us out there that don't like change. And so the idea of using an ultrasound machine is challenging to accept, but hopefully that will change. So one of the things about ultrasounding the lungs is physics. And Adam has just walked in at perfect timing because he's not long ago started his physics exams. So this will be no fresh news to him, but you know, you have to think of ultrasound as a sound wave. It's repeating mechanical pressure. We measure it in a logarithmic scale, and the higher the amplitude reflection, the brighter the echo. And this is key because when we're looking at lung parenchyma, we're looking at artifacts. We're not looking at tissue. One of the reasons that lungs were traditionally never ultrasounded was because of the air. You've got that large difference in acoustic impedance. And you know, if we look at propagation speeds, look at attenuation coefficients, we can see how aerated lung is so different to every other structure that we normally scan. And when ultrasound waves hit air, you know, it's not a good medium for sound because it just goes everywhere. So we don't get reflection from the air back. What we get back is just artifact. Okay. So a couple of words on artifacts with regards to lungs. So I'm having a cup of tea at the same time. So a few of the classic thoracic ultrasound artifacts is acoustic shadowing. So that's when you don't get anything beyond a firm or a strong reflector, so like a rib. Reverberation artifact, which is one of the most commonly seen ones. So that's when we get the ultrasound beam bouncing between two reflective structures. So that's A lines and that's Z lines as well, if you're familiar with those. I've got some examples. A refraction artifact, a mirror artifact that we see, and posterior acoustic enhancement, classically seen, for example, when doing a fast scan looking at the bladder, or for those of you that do any O&G scans, you'll have a similar approach. So not all of this is new, but it's just a reminder. And here's some examples here. So in A lines, they're nice and equidistant from each other. They get less prominent as they go further down the sector. And this is nice. The thought is it's a reflection-refraction artifact from the bright pleural line. Here we've got Z lines, which look or can be confused for B lines, but they're not. This is really important to differentiate because these can be a normal finding. So the thought behind these is that what we're actually getting is very tiny trapped reverberation between the pleura and connective tissue. And so what we see with these, which makes them different from B lines, is that these fade as they go down. They don't hold their brightness and they don't override underlying structures. So you can see artifacts or tissue through them. So this is a Z line normal finding, or can be a normal finding. Then here we've got a mirror artifact, and here we've got posterior acoustic enhancements. Sorry, thanks. Someone in there that we're knocking. Yeah. So, thanks. No, thank you for driving. Yeah, so down in this last image down here, this is a nice example of some posterior acoustic enhancement. We can see how we can see these vertebrae because we've got fluid here. Normally we wouldn't if we had aerated lung. Welcome to Ravi and Benny. I said at the start that I'm in the presence of greatness, and you two have just made that even more so. So I feel more nervous now. Why do we do a thoracic ultrasound? We can assess everything with ultrasound in the chest if you open your mind to it. So chest wall, parietal, pleura, effusions, pneumothoraces, pneumonias, pleural effusions, all things that you would have done before. Diaphragm ultrasound, which is a very useful tool, and some of you in the intensive care unit may use that. There's obviously a bit of evidence, contentious or not, regarding the use of diaphragm ultrasound for weaning. And then other things that we have to encompass as well, upper abdomen and mediastinum. So we can assess the mediastinal structures with ultrasound as well, but sometimes we have to do that endobronchially rather than extrathoracically. So what I'm going to do now is run through a couple of protocol examples, and then I'm going to just talk through some of the pathologies, highlighting, I guess, the features to look for. Again, please ask questions as we go. So choose a protocol and run with it. You know, we know how to do transthoracic echo, we know how to do TOE, we know how to do fast scans, that sort of stuff. We know how to do DVT scans. What I find, especially my trainees, is that they know how to scan, they know how to do a focused thoracic ultrasound, they know how to look for a pleural effusion, they may know how to look for a pneumothorax, but they don't have the structure in their mind as to what they're doing if they're just told to ultrasound the chest. And I think that's one of the deficiencies that we need to start working on, is we need to approach a thoracic ultrasound with the same degree of respect, I suppose, in a way, as we approach a cardiac ultrasound or any ultrasound. So various protocols exist. I'm going to run through two of them. There's the classic blue protocol from Liechtenstein. There's a different series of ED protocols, and then there's just the make it up as you go ones. So for a probe, the lung, pleural cavity, you can use the curvilinear probe. If you want to look at the pleura with greater detail, you should use the high frequency linear probe. And you can take your cardiac ultrasound probe and have a reasonable look. It doesn't give great images of the pleura, but it can be okay to look at lungs and effusions. Just from a protocol perspective, you should always have the diaphragm or the organ on the screen right. When you're starting off ultrasounding a chest, start at that organ aspect and use that to set your gain. So use the liver or the spleen. And don't forget to turn harmonics off if you're using an echo machine, especially to get to see the lung parenchyma, looking for B lines and things better. And obviously, if you're using a point of care machine, I'm sure you all know, if you turn harmonics off, then the resolution, the refresh rate of the machine goes up a lot. Certainly with our GE or LG ward machines, it does. So the protocol that I use is this one. It's a 7-zone left and 7-zone right protocol. Obviously, if you can't see the patient's back, it's a bit limited. So the idea is that when you're scanning every of these zones, there's a certain start point, and you just sort of do that lawnmower style pattern across each zone. Anterior chest, 1, 2, 1, 2, and then from the sides, and if you can have the patient supine, you can just examine there, and then from the back. Note that if you do it in numerical order, once you get past the front, so once you're on the sides and on the back, if you go by numerical order, you will start with a solid organ. You're going to start where the liver or spleen is and work your way up from there. And this is that protocol. So zone 1 is the second intercostal space, 2 to 3 centimeters from the sternum. Zone 2 is the fourth intercostal space, and then zone 3 or 4, 5, 6, and you can have a look at this. This is all available. So this is the protocol that I try and use every time, unless I'm being lazy or doing a focus scan.
So that's called the 14.
So this is it's either referred to as the 7 or the 14 zone protocol. Right. Yeah. This is the blue protocol, which is certainly easier to do, but is a bit less thorough. So the idea is you scan at the points here. So you overlay your 2 hands on the patient's chest with your left little finger or your upper little finger just below the clavicle, and you touch your hands together and you scan over the gap between your ring and middle finger. So put the probe there in 2 spots there, 2 spots there, and then there's the P-lapse point when you're looking for, I've forgotten what it stands for, something syndrome. I've got it written down. So these are the scanning points, much more simple process. And then out of that comes the A profile, B profile patterns that Lichtenstein talks about. And so you can match these up. If what you're seeing here is all normal A lines, you've got an A profile. If what you're seeing here is all B lines, you've got a B profile. And here you've got an AB profile, assuming there's lung sliding in all of them. And then you can take that one step further, and you can look for a C profile, which is consolidation, or here where there's the B apostrophe profile, that's a B profile without lung sliding. And you can work your way through there. So there's some information about this on the FAMUS, FAMUS website. If you Google FAMUS and Blue Protocol, it runs through it all quite nicely. It's very much a point and shoot sort of focused thoracic ultrasound protocol, but it works pretty well. Come on in. How do I get that other screen back?
Yeah, just go.
Cool. Okay. So the batwing sign is the thing that you want to look for. This is normal sonoanatomy of the outer thorax.
Ben, sorry, I just have a question about
Please.
the A profile. So if you just got that.
Yep.
So what is it about COPD, asthma, PE, because they're all really heterogeneous sort of syndromes, yet
Yep.
you're still getting that sort of.
So you're getting normal lung. So A profile means normal lung. You're seeing A lines, which are normal. So if you do a thoracic ultrasound and you see A lines, you're just going to see normal lung.
Yeah.
Because if someone's got a COPD exacerbation, you're not going to see it on ultrasound.
Yeah, absolutely. So you're not gonna. So basically, it's not specific or sensitive for any of those essentially.
Yeah. So,
but if you see that and they've got, then you're either it's normal or they've got.
Or they've got any of those three things. Yeah.
So
yeah.
All right, but essentially you're saying it's not a B profile.
Yeah. Exactly.
Like
So you're excluding certain things. You're excluding significant pulmonary edema if you've got an A profile. Yeah. So
that's pretty much it, isn't it?
Yeah.
Okay.
See, we're not advanced respiratory physicians. Like, we're fairly straightforward, but it gets better. So this is what you should look for: the batwing sign that they refer to, like everything in thoracic ultrasound. They try and give it names and stuff. So rib is through here, lung is through here, pleural line is through here, rib is through here. Apparently, it looks like a bat. I don't strongly agree, but it's fine. The other thing about lungs is you've got to be willing to go off course. So if you can't see the posterior zones directly because your patient is supine, you can't move them, then what you can do is attempt to look indirectly. So you use effusions, you use liver, and you angle the probe to try and see whatever you can. So you have to forget about the rules, which is a bit like what we do when we do ultrasound of critically ill, or echo of critically ill. So just as an example here, this is the thoracic spine, this blue line, and you can't see any thoracic spine down here. Or if the sector was bigger, you wouldn't be able to see any thoracic spine down here because there's normal lung. And so the fact you can see thoracic spine down here means that this is not normal lung. It means there's got to be something else there. It means it's not going to be consolidated lung, because consolidated lung would scatter everywhere. So this tells you this has to be fluid because you're seeing the bone through it. All right, so what I'm going to do now is go through some pathology and some sonoanatomy and just sort of how to look for a few different things. So parietal, pleura, and chest wall, so lumps and bumps on the chest wall. So ultrasound is a great modality to assess them. So you can use B mode, and then don't forget color Doppler. Power Doppler can be useful if you've got sort of low flow vessels. And in terms of probe orientation, if you run the probe parallel to the ribs, you can get a bigger footprint of pleura, and that's the anatomy that we run through there. So the intermuscular septum, layer 4, and then the pleural band through there. We think when we see lung sliding, we're seeing visceral and parietal pleura rubbing on each other. We're not. So we're not seeing that. Well, the theory is we're not actually seeing that. What we're seeing is it's like a layer of fascia and pleura instead. So that's the normal anatomy of the chest wall. And when we're looking at just on the intercostal vessels, so if anyone is looking to tap a small effusion or put a needle or a tube in, Sometimes you've got to take out a small amount of fluid. You can't just put in a whopping tube in the safe space. Sometimes you're tapping a small thing that's loculated at the back, whether that's for diagnostic purposes because they've got loculated diffusion, or whether that's because they're just really frail from a respiratory point of view and they've got a smaller fusion. Because remember, the thing that causes breathlessness is not is the weight of that fluid on the diaphragm and the lack of that normal diaphragmatic mechanics. So sometimes you've got to take out 50 mils or 100 mils of fluid to make people feel a lot better. So if you're going to do that, remember, as you're coming around from the spine, the intercostal vessels can go anywhere. So don't just assume they're they're tucked in. And as people get older, they can go anywhere as well. So intercostal vessels sitting here on both immediate ends of the rib.
Do you do that routinely, Ben, before your
always,
training?
every time. Because it's really embarrassing to go to the surgeons and say you put a needle into an intercostal artery. So yeah, every time.
I'm such a cowboy.
It's fine until you do things wrong. All right, so thoughts? Adam, see you in the back. So looking chest wall, this is the rib here.
Okay, well, there's sort of rib shadowing down beneath
From
that,
that,
I guess.
yep.
So that's fine. And then there looks like there's some kind of, is it hypodense? Is that how you call it?
Hypoechoic.
Hypoechoic, sorry.
Yeah.
Region, which, is both anterior or superficial as well as deep to the rib structure.
Yep.
So some kind of fluid, fluid type collection with an irregular border that extends.
Would you expect fluid to have an irregular border?
No. So not sure why it's irregular then.
Solid.
It's solid. Oh, wow.
Yep. So that's a peripheral lung cancer.
No.
Yep. So a common mistake that we all do is we look at this and we say that's bright, therefore it's the pleura. It's not. That's just the differential thing. So that's a peripheral lung cancer that's just slowly eating its way into the lung. And Emma, you knew you were coming next. So this is a harder one. So the arrows are pointing to where the pathology is. Can you see a rib shadow?
Not really.
Good.
There's a rib missing, and then maybe there's a rib missing, and then this is all irregular, that pleura there, isn't it? It looks bumpy and irregular. Some sort of mesothelioma.
Are you sure that's pleura?
Oh. I was going straight for the money.
Yeah, that's right. So this is quite big. Obviously, you've got no scale here, but there's nothing here at all, is there? Like you've got nothing, and you've got nothing down here. Yeah. So what destroys ultrasound? Yep.
Oh, pneumothorax, that's lung point, is it?
Above it. Because you can't see any ribs. Subcut emphysema.
Oh, subcut emphysema, lovely.
Yeah, that's
very
it.
Nice, yeah.
All right, I'll split somewhere. So yeah, the pleura is tiny. What we see on ultrasound is not what it truly is. The pleura is that layer of blood wrap that goes over the lung. It's not this 2 or 3 millimeter chunky thing. And we can't see the visceral pleura. You might be able to pick it with the high definition ultrasound. What we're seeing is the fascia here, this tissue through there. Just a bit of technical stuff. So pleural thickening. We kind of, a rule of thumb is if it's less than a centimeter, it's probably benign. And that's how we measure it there. Don't forget the pleura runs over the diaphragmatic surface, so you can get pleural-based nodules down here. And this is just pleural thickening from here to here. So this is what we'd see the sliding point from here. There's a small effusion. This is the rib. So to orient yourself to what we're seeing, just look for the structures that you know. Look for a rib, which is this thing, and then we're going to have this be sliding through here, this side.
So what does that show then? Sorry.
So this just shows thick pleura.
Thick, yeah.
Yeah.
So that, yeah. So when it's sort of this bright white part here.
We've got a chunky thing. And so I've got a couple of slides on, I think, in the end. It's similar to diaphragm. With the pleura, it can get thick regularly or irregularly, depends on what's driving it. And it can often be hyperechoic. So a thick strip. But a thick pleura, you'll know when you see it. And you won't see it very often.
We saw it a fair amount in COVID.
Yeah.
Like that
inflamed sort of looking thing, angry looking thing. Pneumothorax. So ultrasound is better than a chest x-ray. And there's lots of data about that. And I'm a big believer in being conservative with my pneumothorax at a personal level. That's for both primary and secondary and traumatic, and there's some data to support all of that. Even if someone's on positive pressure ventilation, although I do have to note that positive pressure ventilation triples the risk of failure of conservative management of pneumothorax, and it'd be very hard to convince someone to not drain a small pneumothorax if they're on a ventilator, but we'll see. I'll keep working on that. One of the things we can't do with the pneumothorax is, apart from looking for lung point, we can't quantify the size of it, but we can do that on a chest x-ray. Because remember, once you start to have a pneumothorax and that lung goes down, then you can't gauge depth. So there are 4 dynamic signs that you should look for pneumothorax, and they all come from that pleural line. There's lung sliding, there's B line or the absence of B line, there's lung point, and there's lung pulse. So lung sliding, I suspect this is new to no one. So you're looking for this thin, bright sliding movement of the pleura that you see on normal ventilation. Remember, if you're scanning someone and you're scanning them at the top, then you ventilate the upper zones of your lungs less, so you may not see it very well there. If you're not sure, look on both sides, and if on both sides it looks very hard to pick, then it's probably not a bilateral pneumothorax. And the chance of having pneumothorax on one side and the air tracking across the other side, what we call a buffalo pneumothorax, they're very rare. So if you can't use B mode to see the pleural sliding or the lung sliding, then switch to M mode, and this is where they get those seashore and stratosphere signs, which is this. So this is normal lung sliding, so subcut tissue and skin and stuff, pleural line there, and then this is the lung that's just constant, that's generating artifact. If you've got a pneumothorax, then it looks like this. You see nothing, and then this is the lung point. This is where you go from having no lung to having lung, and that's just the lung as the patient breathes in and it comes up to reach the pleura, and all of a sudden you can make sonographic contact, then you see it, and then it comes away again. So one of the things you can do is, if you've got a patient who's, for example, lying supine, be they critically ill or intubated or got broken legs and can't get out of bed, you can mark on their chest just where you're catching lung point. And then you can come back and scan them 4 hours later, 6 hours later, 12 hours later, and see where that is, and see whether that lung point is getting higher, so the lungs inflating more, or going down further, so the lungs collapsing more. It's an easy way to track it, and you can do that, fairly short period of time. A pneumothorax should expand at the rate of about 5% a day. So if you're happy that it's not getting any bigger, then it's going to start to get smaller. So B lines, so what you look for with the pneumothorax, you look for the absence of these, because B lines mean lung. And B lines are where we're getting the ultrasound trapped. Trapped, I say that, use the term loosely, between the different acoustic impedance structures. They move with respiration and they dominate everything that's on top of them, and they look like this. So this is a B line, and see, if you think back to the start where I talked about Z lines, which kind of faded away, B lines don't. B lines go the full length of the sector. They will always go the full length of the sector. And if there's any structure underneath them, they will obliterate it. So they dominate.
So then they talk about, is it more than 3 B lines per sector or something? So B lines can be normal,
yes, absolutely,
but less than.
So in any given interspace, either 3 or more is abnormal, or greater than 3 is abnormal, depending on which source you read. I go by the general rule of 3 or more is abnormal. That's a few caveats. It has to have a reason to have the lung have a problem. You're more likely to see normal B lines, so a couple of them in the basis. Mm-hmm. You're more likely to see normal B lines in athletes. I don't know why. But yeah, a couple of B lines in any given interspace can be normal, but certainly when someone's got significant pulmonary edema or fibrosis, they just dominate the screen. They can be really big. But if you see B lines, it means you're seeing lung, therefore there's no pneumothorax. Lung point, so again, you look for where lung is sliding, so that lung sliding sign, and where you lose it. So if you imagine back to that M mode shot from back here, so you have the lung sliding is through here and no lung sliding, and you can see that visually with pleura as well. So it will move with respiration. You can see that in effusions as well. And then last of all is lung pulse. So lung pulse is the transmission of the cardiac impulse through lung tissue. If you can see it, it means that that the lung is in contact with the chest wall or the internal chest wall. So therefore, there's no pneumothorax there. And if you look at it on M mode, what you can see is lung pulses like this. You see it bouncing in and out. So pneumothorax. Fluid in the pleural space. So there's a whole lot of different reasons why you can have fluid in the pleural space. Standard effusion, it can be pus, it can be blood, it can be from the abdomen, it can be from someone having pranged lymphatic vessels, it can be urine. This is the bread and butter of what you guys do, I'm sure, and you know how to do this, so I'm not going to try and teach you how to suck eggs. I do want to point out that that X centimeters depth by 20 thing isn't really a thing in much literature. My little jab at my ICU colleagues. So certainly there's some earlier data that showed that holds true with small pleural effusions when the patient's in the right setting. So sitting at the right angle, which from memory is about 15 degrees, and spontaneously breathing, and the effusion was smaller. But certainly once the effusion gets a bit bigger, the volume increases significantly greater than the size does. So you can have a much bigger effusion than what you realize. You get beautiful posterior acoustic enhancement and loculations. So from a respiratory perspective, how you see the effusion on ultrasound makes a hell of a lot of difference to how we'll manage it. So all transudates, so heart failure and liver failure and kidney failure, will be anechoic. Like they're just going to be. If they've been sitting in the chest for months, you can get a few fibrin strands. As a general rule, all transudates will be anechoic, but not all anechoic effusions are transudates. So if you think that your patient's got a parapneumonic effusion or an empyema and you don't see septations, the fluid dimple, you still need to put a needle in and get some out to prove it. Okay, you have to assume that everything is exudative until you prove otherwise, or until you're really comfortable otherwise. Simple effusions will be free flowing. They'll always move with gravity. They won't be loculated. Complex effusions will have loculations and septations. The longer you leave it, the worse it gets. And the more complex it is, so the more septations through it, there's a greater chance of the pleural rind forming, and then this patient's lung will never be the same. You end up getting non-expandable lung. And you can see if the effusion is big enough, you get paradoxical diaphragmatic movement. So when the person breathes, the diaphragm will invert and go the other way, which is a marker that they'll get symptomatically better if you take it out. So this is Light's classifications of effusions. Again, coming from a respiratory perspective, I use this a little bit. Some of my colleagues won't. I use it just for the sake of teaching my trainees about it mostly. Anything that's like class 3 down has to come out. All the fluid has to come out. Obviously, you've got to tap it to be able to do this, but it's always got to come out if it's any of this sort of stuff down. The longer you leave it, the worse it gets. And you can end up getting things that look like this. So this is beautifully complex and septated. And you can see why this person would be sick, and you can see why just putting a tube in is not going to work. And even if we put in lytic enzymes into it, it may not work. Probably a surgical fix. And then you can have, you know, 1 or 2 loculations, which are really easy to miss. So when you're scanning effusions, go from perpendicular derivatives to parallel, scan through all planes. You have to really convince yourself there's not septations there, because if you see 1 or 2, then immediately this thing has to become in your brain that it's exudative, not transudative. So you got to tap it. And if you leave them too long, then what you can end up getting is non-expandable lung. And this is a real shame for the patient, because it means that that lung's cooked. So it will never completely re-expand. We cannot fix non-expandable lung. We don't typically catch this until it's too late. And this is the situation where you've got a chest tube in and the fluid stops draining, but the tube's still patent. And the lung's not completely up. So this will typically hurt by the time you've drained out enough fluid for them to demonstrate non-expandable lung. And if you try and suck it out, like if you have that tube-on suction, then you can try and pop open the lung, you get re-expansion pulmonary edema, or you get what's called pneumothorax ex vacuo, which is like a vacuum-induced pneumothorax in the lung. So that can happen if we're too aggressive trying to suction stuff out, or if you've got proximal airway obstruction, or if you've got visceral pleural fibrosis, because the way that I explain this to people is you've got your normal lung and you've got that visceral pleura over the top of it, which has been inflamed and angry for a while, and that's turned into a belt around your lung, and that lung can therefore never open up past that belt. even if you take out the fluid that's in there, that inflamed exudated fluid, the lung is still not going to expand, and the body hates an empty space, so it will fill that space back up with fluid again. So that's effusion. I'll scratch over now to pneumonia. So lung ultrasound has a limited role in pneumonia. It's good if you've got something that abuts the pleura, so a decent lobar segmental pneumonia. But if you've got interstitial disease or focal disease, you're not really going to see much. It's easy to pick nice hepatized lung. It'll be full of fluid. There's very little air in as a result. But as the lung starts to expand and you get better aeration, then you can sort of underestimate it. There's a few classical features we look for. Again, this is predominantly a B mode and a color Doppler interrogation. So you're looking for hepatization, which is beautiful when you see the liver and the lung next to each other and they both just look the same. You can find cysts and abscesses, and you can use ultrasound to directly drain a lung abscess, as long as you're careful. The few features that are classic in pneumonia and that I want to hear about if someone tells me they've ultrasounded pneumonia is if there's dynamic air bronchograms, if there's fluid bronchograms. So dynamic air bronchograms are when you've got small bronchi that are aerated and they generate an artifact, and that aerated lung is sitting between consolidated parenchyma. You get these nice little step-like lenticular lens-shaped small echoes, and they should branch out a bit like a tree, and they should move in intensity and change intensity with respiration, which is different to those that you see in atelectasis. So this is one of the ways you can pick pneumonia from atelectasis. You see fluid bronchograms, which look like nice small blood vessel pipes, which are airways full of gunk. And then there's the shred sign, which is just where that abnormal and normal lung interplay. So this is a nice picture of stole, which shows sort of 2 of the 3 or 3 of the 4. So we've got, this is lung, although it doesn't look like it, so clearly it's hepatized. We've got a fluid bronchogram sitting in through here, and we've got air bronchograms, these small line-like really shadows that if you squint will look a bit tree-like, and this is just those small airways that still have air in them holding their shape. And you see it just kind of looks like they're all stepped on top of each other as they branch off. So that's an air bronchogram, and as someone breathes they will move and change in intensity. You can put color Doppler over the top of it, and you should see normal vascular distribution, and you can use contrast. So there's some interesting stuff now where we're using contrast enhanced ultrasound. You can use that to pick whether something's pneumonia, or whether there's a problem with the bronchial vasculature, or whether there's infarction or abscess, because infarction and abscess won't have any flow from the contrast, sorry, whereas consolidated lung will. And then here, so this is an example of pneumonia. So this is pneumonic lung, and this is the abscess sitting nice in here. So you could easily confuse that for, you know, a small pleural effusion, but it's not. You've got this posterior acoustic enhancement, and you have normal or similarly close to normal lung up through here. And this is something that you could drain if you needed to, if the patient was really sick. Again, there are some of my colleagues in the respiratory world that would never drain a lung abscess, but as long as you're going in through consolidated lung, you're going to minimize your risk of harm, and it can be a useful technique. And that's why I should use lung ultrasound. So this is comparing to chest x-ray. It's a very good tool. So here's some examples of pneumonia mimics. So this is in homogeneous consolidation. We've got large air bronchograms. These are huge. This is a big aspergillosis and aspergilloma. And here we've got these small speckle starry night style ones, which don't form that branching pattern, which is an organizing pneumonia. So similar but different.
You're just letting people in.
Yeah.
Thanks.
Yeah. Interstitial syndrome. So again, this is words that we throw around a little bit. So make sure you turn harmonics off when you're looking for this, because we just want to see lung parenchyma and we want to see artifacts. So we call this thing interstitial syndrome. In practice, it's actually more partial de-aeration of the lung is a better term. And this is where we're looking for those B lines that I spoke about before. So here, this is a Z line and this is a B line. And it's really important to pick the difference. It's a Z line because it's fading away. It's not destroying the A lines, you know, it's just sort of going over, it's going around or past or through them. The A lines are still visible. This is a whole series of B lines that are coalesced together, big, bright, like a torch. These have to be correlated to what you think's in front of you. most commonly we see them in cardiogenic APO. And so you can use this to pick, you can use this in the emergency department or in the patient suddenly drop their bundle. You know, you put a probe on their chest, you see a lot of these, it's APO, but it's not a COPD exacerbation. And there's some nice studies, I've just put one there, I can get references if people want, where if you do this in the ED, then you can change or improve the diagnostic accuracy. Because how often do we get these calls for these people that have a bit of heart failure, a bit of lung failure, and they're breathless. And I can use lung ultrasound or thoracic ultrasound in the ED to make them be someone else's problem. So it's a really useful thing for me. And you can theoretically use them to pick non-cardiogenic APO from that, which is cardiogenic. And here that's based on the nature of the lines. So non-cardiogenic will have these funny pleural indentations, which are probably due to subpleural consolidation, whereas cardiogenic should have a fairly smooth pleural line. Otherwise, they look about the same.
And you just give them a drug called coamoxifluzicab.
Coamoxifluzicab. And occasionally that comes with the side serve of macrolide. And B lines are one of the things that are being investigated a bit more. So we've shown that they have a good role in sort of assessing high altitude pulmonary edema, patients on hemodialysis, interstitial lung disease, which is a whole different kettle of fish, and preeclampsia as well. They're sort of predictive of some of these things. And really use them to ask yourself the question of, should I give this patient fluid? And if you see B lines, then the answer is probably not. And again, I've had to make a note to our cardiology colleagues for finally endorsing the role of lung ultrasound in the 2016 guidelines. I'll talk quickly about PE. We're actually almost done. So remember, what we look for here is the sequelae of PE. So we're not going to see anything on the lung ultrasound or a thoracic ultrasound, you know, directly associated with the clot. We're going to see the consequence of that. So when you start to hyperperfuse that last bit of lung because of the pulmonary embolus, then the surfactant production stops, the surfactant goes, and then you changing the tension forces within that alveoli. You get interstitial fluid and red cells flowing into the alveoli, and you can see that. If you're lucky, you can see signs of an infarct, but otherwise what you're seeing is just congestion and loss of aeration. When you're scanning for a PE, you have to do a whole of chest approach back to that sort of 7 or 14 zone that approach I talked about at the start. You're looking for these small subpleural lesions that show echo pore consolidation, and they're typically avascular. And if you combine it with an echo and a lower limb Doppler, then you can feel fairly confident on whether someone's got thromboembolic disease. So I've got an example. So this is just a meta-analysis, 3 multi-center studies where they tried to use ultrasound to diagnose the PE. And if you combine sonographic findings with the presence of pain, then it's pretty good at picking up. So you scan the whole lung and you look for things like this. So again, we've got this posterior acoustic enhancement down here. We've got a few B lines on either side, but we've got this pleural line comes up through here, and a little blip, and then the pleural line again. And this is just a little area infarcted lung. So that means that somewhere back up here, it's a pulmonary embolus, and that's died. And likewise here, same thing. So it's peripheral, it's sort of not very big, it's a wedge or it's rounded. There's no air bronchograms, and if you put color over that, you'd see nothing. It's clearly abnormal because we've lost our pleural margin. And so this is a infarct, and if this is big enough, then you end up seeing that sort of Hampton's hump sign on chest X-ray, which you see 5 days after the event. This you can see at the time. So diaphragm, I've got 2 slides left, I think. I'll just let this next person in. Yeah. So just a word on diaphragm ultrasound, because again, the role of diaphragm in weaning and diaphragm strength and mechanics in weaning is a different talk in itself. But I guess a few simple pointers. So when you want to measure it, a lot of the data out there is only done unilateral measurements, more from the right, because you can use the liver. So you be between the mid-clavicular and anterior axillary line, and you kind of look up and in, and you want to get your line of intonation sort of perpendicular to the diaphragm. And you should see it move about a centimeter with tidal breathing, 1.5 centimeters with sniffing, and 3.5 to 4.5 if you get into a deep breath. And so this is a nice little picture I've stolen from down here. And what you're picking here is the diaphragm. So you can just pick tidal variation in movement there. So that's how it should be with respiration. And then in terms of thickening or thickness, you will often get a better result if you switch to a high frequency probe, because you're trying to catch the diaphragm when it's running right next to the chest wall. So you have to be low and you have to be a bit sort of anterior axillary, and you want to try and catch the diaphragm in cross section like this. This is the diaphragm here, and you can measure it just from point to point. So this is lung over here where it started, and this is peritoneal cavity. So you can imagine where we are sitting right over the side here, and you've come right up against this diaphragm and you can measure it there. So there's some data about diaphragmatic thickness and how much it should thicken when you have someone do good inspiration, and that's sort of generally accepted numbers there. And just slide on intubated patients, there's data out there, and this is a very small sample of the data that shows that once someone's been tubed for a couple of days and they're not spontaneously breathing, then the diaphragmatic thickness starts to go down, the diaphragmatic movement starts to go down. And yeah, at least from this one study that I've got here, is the second point down, is disease severity, going for Pucci scores, steroid use, all those things didn't affect it. The main variable was duration of ventilation. And then my last slide is this one. So this was a patient that I had a couple of years ago that was admitted for pneumonia. Hope this will play. And scroll back towards your chest. You can see going that way. Talking to the patient that was doing it. Okay, towards your arm, it goes down that way. So nice right upper lobe pneumonia. When I was working in Cairns, this patient had flown down from somewhere up in the Cape. A young woman, early 20s. And when I put color over that, some of these were vessels and some of these were air. And so I did a percutaneous biopsy on the ward with a true cut needle. It was triple negative breast cancer. So sad way to finish.
So you've got diaphragm at the bottom there.
No, this is here.
Oh, okay.
So this is here. Yeah. So this was just a unusually round opacity that was called pneumonia in a patient that had been losing weight and wasn't doing very well. And there was nothing to feel or see, and she'd been in a place where all they had was chest x-ray. And so she flew down and got admitted through our emergency department under my team for pneumonia, which was that.
So that's just thick. What's that at the base?
So this is all just, this is lung, and this is just invaded straight into the lung. Oh, so I could put a needle 8 centimeters into that, and it was all like no harm.
Is that maybe a fissure or something then, like within the...
I think it was just all destroyed lung. Yeah. And that is the end. So that's sort of a respiratory physician's guide to thoracic ultrasound. If there's any questions, please ask. I didn't go into a lot of detail about the things that you do on a day-to-day basis, like taking out a bit of fluid or looking at pneumothorax, but I thought I just wanted to make people aware of the greater application of it. And with a bit of luck, as my generation comes through, we'll be using it more and more, and hopefully that will spread across other fields.
Ben, I had a question. It's Robbie. Have you used lung ultrasound for assessing recruitment during ventilation?
I have not, no, and I not familiar with any data about that. Not of lung recruitment. It may very well exist, but it's not what I know about. Anyone in the room? No. Certainly, when I was having a bit of a preparation for this, I didn't come across much of using thoracic ultrasound for that, but that's just because I guess I didn't go looking directly.
It's hard to quantify, right? I mean, you're just looking for atelectasis, right? And just minimizing the amount of atelectasis. Is that what you mean, Ravi? That you just try and determine reduced atelectasis after and before the recruitment maneuver?
Yeah, I've seen a couple of videos on YouTube, showing dramatic change in the B lines and but I have not used it personally as well. I've somehow not found time when I'm adjusting the ventilator.
It'd be interesting if it's showing significant changes in B lines, because that implies you're changing the interstitium of the lung, which will be less from increasing aeration and more from how you've changed pressures and filling pressures, I wonder. Because if you're talking about increasing recruitment and increasing opening up small airways, then I don't know how quickly that would cause dynamic changes in B lines. I wonder what the mechanism for it is. I suspect we don't know. There's a lot of things about the mechanisms of lung ultrasound that the boffins don't know, and yeah.
Thanks.
Can I say something to that question, just because I have looked at a couple of papers recently?
Yeah, please.
And yeah, there are a couple of post-op studies, not with large numbers. I'm sorry, I haven't got the exact names of the papers here, where they look for atelectasis just as clusters of B lines with pleural line abnormalities. They performed a recruitment maneuver and then immediately put the probe back on again, and the little areas of atelectasis have gone. And one was in kids post-cardiac surgery, and the other one I think was in obese patients. The only caveat to the study is that you can't tell when you've overdone things, because it's great when the little B lines go away, but then when do you stop? So you don't know how much recruitment to do unless you're keeping the probe on there the entire time and watching it the whole time.
Yeah.
Sorry, that's my 2 cents.
Yeah, no, very cool.
Yes, can I say something?
Yeah.
Hello, everybody. I am Dr. Calderon from Mexico. Thank you for inviting me. Well, this is a very good topic. Actually, in Mexico, you know, there are some colleagues enthusiastic about using lung ultrasound in terms of recruitment maneuver and so on, trying to see when the B lines or consolidations disappeared after a recruitment maneuver. And we concluded that this is not only not useful, but also can be dangerous, you know, because something that is very important when we are ventilating patients is try to keep a protective mechanical ventilation. And when we try to disappear consolidations or increase the aeration of the lungs, increasing the pressures in the lung, it can be deleterious for the patient, because you know all of the lungs are overinflated and so on. That's why we think that lung ultrasound should not be used in this specific setting or application. This is our point of view.
I think that to echo that one, I think that the lung, even in a healthy person, has heterogeneous aeration. And if you take someone that's critically unwell, unclear fluid status, perhaps, you know, where you're looking at, you may see obliteration of B lines and atelectasis in that one point, sure. But what you've done to the rest of the lung, you have no idea about. So you may optimize one small portion, even if you're doing it dynamically, but what you've done to the rest of the lung and the interplay there would be hard to assess. And welcome from Mexico, Don Dieras.
Thank you. Thank you.
All right, any other questions? If not, I'll say thank you everyone for coming in.
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.